Thank you so much for a wonderful introduction. This moved my heart to hear the ways in which our paths have crossed over the years. And one of the things you hope as an educator and as somebody who tries to challenge things is that people will try to come to grips with some of these issues that we all struggle with. And sometimes they take on leadership roles and move things forward as you have. So it's really a great privilege to be here with you and to be back with you all again to talk about these issues. Unfortunately, I speak no Spanish. So you're going to have to bear with the translators and me speaking English, and I apologize for that. But I'm going to talk about caring on the edges, about last resort options for medical assistance in dying. I have no significant conflicts of interest, except I am an advocate in this area. I have a position, and it's not a secret, my position, that I think this practice should be more out in the open than in the secret and under the covers. So I'm going to talk about some background clinical issues. I love to start out with these photographs of Imogene Cunningham about people who are alive and functioning into their 90s. And when we use medicine's powers to keep people alive and functioning into their 90s, we are doing a wonderful thing. The hope was, as people are living longer, that they would live healthy quite a bit longer, they would live sick perhaps a little shorter, and they would die peacefully. What's happened instead is people live healthy a little bit longer, they live sick a lot longer, and at the end of sick, often they, or even more often their families, are having to make very difficult decisions about whether to keep going or whether to stop, because about half of people lose the ability to make decisions for themselves before they die. So how should a healer approach these kinds of things? What does it mean to be a healer if you work in end-of-life care? So we can't think in terms of curative or restorative disease-based model because it's not clear what a healer should do, particularly if death is coming on. If death is a medical failure, then we are going to fail every time if we care for people long enough. Now, there is a solution to this, and that is have a fragmented healthcare system and have somebody else take care of the patients when they approach the end of their life, which is probably the model in the United States now, hopefully not so much in Spain. So what would a broader model of healing look like if you care for people who are very sick toward the end of life? The issues become maintaining wholeness or personal integration. It might be a commitment to find meaning throughout the process and to maintain connection all the way through to the patient's death. We have learned from the folks in hospice that there is this opportunity for growth and closure at the end of life. We might try to facilitate that, and we might say that we're going to go through this process together. That's where our healthcare system should be going. This is a picture of Elizabeth Kubler-Ross. I probably should have Dame Cicely Saunders for the European part of this, but they have really awakened us to the possibility that there are wonderful things that can happen when doctors and patients and healthcare providers work together toward the end of life. I love this picture because I don't think of this man doing a lot of deep death talk. He's probably going to be talking about giving away his tools to his grandchildren, or perhaps some of the things that he has saved. But these are things that his grandchildren will savor forever if they are able to hang on to those pieces of this man. There is a technical side to this work. You really need to know what you are doing if you're going to care for people at the end of life, particularly in terms of pain and symptom management. It's not rocket science most of the time, but it does require creative commitment and quite a bit of knowledge. And when we use medicine's powers to help people die more peacefully, we are doing a very good thing. This is where I push the envelope a little harder than other people do, because we're all going to go there someday. And if we are all going to go there, we might want to think about how we want to be psychologically, spiritually, and socially at that phase of our life. And it will require a rethinking of the medical model in that context. So what are some of the potentials and limits of hospice and palliative care? So palliative care and hospice, I'm going to define them at least in the U.S. terms. Palliative care is the biological, psychological, social, and spiritual care for people whose diseases are not responsive to curative treatment. The goal of palliative care is to produce the best possible quality of life for the patient and family. So the focus is patient and family. You will notice in those definitions, there's not a lot of death talk. So you don't have to be dying to be in palliative care. You have to be sick. Hospice, on the other hand, is a program dedicated to provide palliative care for now terminally ill patients, patients who are dying and accept that they are dying, and it focuses on the patient and their families. This is a graphic that's used, a lot of versions of this. They're very similar, but you can see on the left-hand side of this scheme that people who might be getting very aggressive life-prolonging therapy, think a heart transplant or a lung transplant. If they get the transplant, they may well live a long time, but they are quite symptomatic while they're getting that. And a good percentage of them are probably never going to get the transplant. So why not, at the same time you're trying to give them the best possible disease management, why not give them the best possible palliative management? And as people get sicker, the amount of palliative management goes up and up until hospice, when that is the sole job toward the end of life, to palliate symptoms and to provide partnership and connection. So the palliative care conversation is a little bit different than many other medical conversations, in the sense that we're going to hope for the best. We're going to look at all the medical options to treat the disease that might be available. If we're getting into long shot, very invasive things, we better make sure that the patient has his or her eyes wide open about what they're getting into in terms of odds and probability and how much suffering is involved. But we're going to make sure there's informed consent. And at the same time, no matter what the path is, we're going to attend to the present, make sure pain and symptoms are adequately managed, depression, anxiety, all those symptoms that might be occurring. And if they are willing, we're also going to prepare in case things don't go well. So they don't have to go there, they don't have to explore what are they most worried about, but it ought not to be because we haven't offered them the opportunity to talk about these things. So there are some challenging, when I have to have a hospice conversation with a patient and family, particularly for the first time, it is not a good day for them, right? Because they have to be told some very hard things to accept. It really is a classic bad news discussion. I have to say that treatment isn't working very well, that they're more likely than not to die in the next 6 months, that they're not required to die in 6 months, but they're more likely than not to die in 6 months, and that to go on to hospice, they have to let go of going back and forth to the hospital. So many patients are appreciative of that, but they don't want to give up on everything. They might want to continue easy treatments. They want to keep open the option of going back and forth to the hospital, and they may not get into hospice in that circumstance. But on the other hand, most patients who get onto hospice, looking back, are very grateful that they got there, and they often say, gee, I wish I had gone there earlier. I wish I had not gone through that last week or few months of near-futile medical treatment. So some patients may push things a little further. What are my options if suffering becomes unacceptable? So I appreciate what you can do in hospice. I appreciate your efforts to relieve my suffering and to attempt to do that. But what if my suffering gets very hard? So the first and foremost, when people talk about that, we redouble our efforts to make sure they're getting best possible standard of care. So are they getting state-of-the-science disease-directed treatments? Are they getting full-fledged palliative treatment? Are we doing everything we can to treat their pain and symptoms? Are we helping them with decision-making so they know what they're getting and not getting? Are we providing added patient and family support? And then hospice care, if they accept that they're dying, are they on to hospice? Should we put them on? And if not, why not? So what are some of the limitations of hospice and palliative care? So the good news is hospice and palliative care work most of the time. The bad news is they don't work all the time, right? All the time, all the way through. And when we tell people that we can relieve 100% of their suffering from the point of diagnosis all the way through death, they know it ain't so. And what they're going to think if we say things like that is that maybe we'll just not see it if it's not what we want to see. So we have to have a pretty frank look that there are going to be exceptions, there are going to be tough cases, and some of those tough cases are uncontrolled physical symptoms like pain and shortness of breath, nausea and vomiting, delirium, the symptoms that are part and parcel of end-of-life care. And then if we're going to talk about suffering, we're also going to have to talk about psychosocial, existential, and spiritual suffering. And the notion that we would have solutions for 100% of all those dimensions of suffering just doesn't make sense. It doesn't ring true. Furthermore, some of the dependency and side effects that are required toward the later phases of these diseases are unacceptable to some people. So if a patient is on life supports and they say they're ready to die, we say, listen to the patient. They know what they want. They've had it. Take the life supports out of that equation and the patient says they're ready to die, there must be something wrong with them. They must be weak. They should really try harder. And in fact, those questions should both be posed for both groups of people. So there are two things people are worried about. One is I wonder what things are going to look like down the road, particularly as they're looking toward hospice. Who's going to be my doctor? Are they going to take care of me all the way through this process? If not you, then who? And people are also willing to talk about this. What are they hoping for? What are they most afraid of? And when people say they're most afraid of untreated pain, I personally breathe a pretty big sigh of relief because I know pain, and I'm not afraid of it, and I know that I can use huge doses if that's what it takes to relieve pain at the end of life. But there are other symptoms for which I don't have good or simple solutions. But what people are really looking for at this stage is who's going to be my clinician working with me throughout this process, no matter what. And those who know who that person is going to be are then free to worry about other things because they know they can count on you to care for them throughout the process. But if we do make such a commitment, I'm going to be there with you throughout the process. We also have to be prepared that if things get tough, we're going to have to work through that with the patient and family. So when that happens, we're going to ask a lot of questions about that. Why are things so unacceptable right now? What's the worst part? What's the hardest part? Tell me more. We're going to use good interviewing skills to get some depth in that. And sometimes it's uncontrolled physical symptoms. Sometimes it might be a psychosocial problem. The family may be getting fried caring for the patient at home. They may be asking spiritual or religious questions. How could a caring God have done this to me? Or they may have become depressed clinically, in which case the answer might be treatment of depression. But it also might be that they're having severe, uncontrolled, intolerable suffering. So if it is that latter group, it's intolerable, uncontrolled suffering, then we have to think about what are the options people have in this circumstance. And this is a list of what the options might be in order of decreasing societal agreement about acceptability. So the ones on top, we agree pretty much are acceptable. Middle zone, we're sort of in agreement, and the red zone, there's a lot of disagreement. I'm just going to briefly describe what each of these is. So accelerating opioids for pain. Opioids are still the mainstay of treatment of severe pain, particularly at the end of life. As we move opioids upstream, it's much more complex and difficult. But at the very end of life, opioids are the backbone of the treatment, and the dose should be proportionate to the level of pain. The data that opioids hasten death at the end of life is very weak, unless there are very high doses or sudden changes in dose. So the risk is minimal with usual pain management, and death, if it comes in this circumstance, is unintended. That's not why we're giving it. We're giving it to relieve pain. What about stopping life supports? Again, there are many life supports that people are on. Some of them are quite evident: mechanical ventilators, dialysis, feeding tubes, defibrillators. All of those are things quite visible, and those can be stopped if they no longer meet a patient's need, even if their desire is to die sooner rather than later. So these treatments may be withheld in the first place, or if they're started in one circumstance and that circumstance changes, they can then be stopped in a later circumstance. These decisions can be made by patients if they are able to do that, or by families if they are incapacitated based on substituted judgment, trying to make the decision as the patient would want you to if they could understand all that was going on. Again, wide agreement that this is permissible, although we start to get some shakiness. There are some religions in which stopping a treatment is much different than not starting it in the first place. Orthodox Judaism, for example, much different religiously. Now we're going to move into a gray zone: stopping eating and drinking. This has been a relatively recent player, although it's probably been around since the beginning of time. This is different from the natural stopping eating and drinking that occurs as a patient loses their desire, gets weaker and weaker. That's not what we're talking about. This is the result of an active patient decision by somebody who's able to eat and drink because they're ready to die now. So it requires considerable patient resolve. Patients have to be very determined to do that. Actually, getting hunger is not the problem. It's thirst that's the problem. Thirst is very hard to manage. There are ways of managing it. It theoretically doesn't require clinician involvement, but it really should, because symptoms occur as the process unfolds. And toward the end of this process, people often become delirious. And then how do you manage that? Then there's palliative sedation, possibly all the way to unconsciousness. In this case, the sedation needs to be proportionate to the level of suffering. I will say it's most comfortably used in the presence of severe physical suffering. If the suffering is more purely psychological or spiritual, then sedation would be a little tougher to justify, although I think we could have a discussion about that. Generally, when people are sedated, life supports are withheld. You're usually using benzodiazepines or barbiturates, and the process can take days to weeks. Patient who is sedated and not given food or fluids usually dies of dehydration or complications. And they're unaware of the suffering for the last part of their life. Justification is usually a combination of the double effect and withholding of life-sustaining therapy. And when you combine those things together, the double effect becomes a little bit more complex to use for those who are religiously inclined, for whom that's a core construct. And then the next is physician-assisted death, or also called physician-assisted suicide. Here the physician provides the means, usually a prescription of barbiturates at the patient's request, but the patient must take or not take the medicine by his or her own hand as the final act. The possibility of this is very important to some people. The physician, even though they are not delivering the medicine, you're clearly responsible morally as an accomplice in helping this patient to die. This is also called physician aid in dying and physician-assisted suicide. And then finally, voluntary active euthanasia. Here the physician provides the means at the patient's request, but the physician also carries out the final act. It includes both sedation and then a lethal injection. It can respond to a much wider range of clinical situations than physician-assisted suicide. The physician in this case is both an accomplice and the final actor. And the legal prohibition, at least in the United States, is much clearer for this practice than it is around physician-assisted suicide or physician aid in dying. So there are some conceptual issues about the suicide label. There's a lot of, if you debate this issue by opponents or people who are in favor of it, those who are in favor try not to use the suicide language. Those who are opposed try to use suicide language. And the problem is that suicide has many complex definitions. And the most difficult one is mental illness suicide. So if a person is wanting to end their life because they're depressed and not seeing their situation clearly, we clearly should try to prevent that. There's also sometimes heroic suicides. Think of a warrior who jumps on the bomb to save his or her crew. That would be a different kind of suicide. And then there might be rational suicide, somebody who is thinking clearly about what they need, and this is the only option they have. And if you believe that that's as rational as other decisions, like stopping a life support, then it might be permitted. So the politics of this label, if you're an opponent of the practice, you want to call it suicide. And if you're an advocate of the practice, you want to call it aid in dying or physician-assisted death because of the self-destructive part of suicide as a definition. This practice, used in the right context, is really more self-preservation in the eyes of the patient than it is self-destruction, and much more similar to stopping life supports versus taking an overdose. Some data from Oregon, which is in the United States, where there's the most longest history. 1 in 6 of terminally ill patients talk to their families about it. That's quite a lot, right? 1 in 6. 1 in 50 talk to their doctors about it, and it only accounts for 1 in 300 deaths. So most people want to talk, and that is one message of this talk, is to know that your patients, if you are open to hearing about it, will talk to you about this. 1 in 6 will probably do that. Some want the possibility of an escape that they will never activate. So I'm a safe person to talk to about these things. I talk to a lot of people about these kinds of questions, but very rarely does it actually get activated. So relatively few will act, even in a legal environment. So physician-assisted death in the United States is now legal in 8 states and the District of Columbia, so there is some movement toward legalization. It is not legal in New York State, where I'm from. And there is a lot of legislative activity, still very controversial in the US. In Canada, both physician-assisted death and euthanasia have been legalized across the country. So this is a brand new a law that was enacted in 2018, and the terminal illness requirement is a little soft on this. So it has to be an illness that has a grievous and irremediable medical condition, meaning it's not going to get better. It causes suffering, but death has to be reasonably foreseeable, which is different than terminal. It doesn't have the 6-month requirement. Data is just being collected now, and there are legal challenges in Canada trying to say, well, maybe it shouldn't just be for people with an irreversible condition. Maybe it should be more of a choice. So wherever you set the boundary, people are going to be trying to restrict that boundary, and people are going to be trying to extend that boundary politically. Here's a brief look. I won't go through all the countries in Western Europe where there is some practice of physician-assisted death. Germany is probably the most interesting, where the practice is legal, but they have taken doctors out of the practice because of their long history in World War II of problematic killing. So doctors may evaluate the patient, but then there are volunteers who actually provide the medication rather than having doctors. So it is another model. So what about an open versus a secret practice? Again, where I'm in New York State, if there is a practice, it's secret. In Oregon, it's going to be open. In Spain, definitely secret. So if we are going to allow this practice, we ought to have safeguards for it. We have safeguards for all other really challenging things in medicine to protect the vulnerable from error, abuse, and coercion. We want to make sure that people who are thinking about this have access to palliative care, not just access, but it's being delivered very well. We do know that the risks cited for assisted dying and voluntary euthanasia are also present for last resort options that we are very comfortable with. And if we are going to have safeguards, they should balance flexibility and accountability, privacy and oversight. So there is a balancing act that goes with safeguards. The categories of safeguards are generally agreed upon. Palliative care has to be accessible and found to be ineffective. There has to be rigorous informed consent, some diagnostic and prognostic clarity about the patient's illness, an independent second opinion, ideally by somebody who has real skills in palliative care, and then documentation and review so we can study the practice. What are the risks of the don't ask, don't tell, or secret policy? Well, it basically says that access will be very uneven and unpredictable. If you have a doctor who happens to believe in this and is willing to take a risk on your behalf and not tell the truth part of the time, then you might be able to get it. Well, I will tell you, if I'm the terminally ill patient, that's going to scare the heck out of me, because I'm going to know that's not a very reliable system. So it also discourages explicit conversation. These are conversations like when we have a conversation about stopping a life support. It's where you want people to be incredibly honest and frank with one another about what they're really thinking and feeling. So there's a risk of misunderstanding. There are no safeguards to ensure adequate palliative care and evaluation. And if you are assisted in this way, everybody's got a big secret to keep because talking about it might be legally dangerous. So it could lead to bereavement problems. Now, there might also be risks about being more open or explicit about last resort options. Some patients and families will clearly be frightened by this. If a doctor can do that, how can I be sure they're going to always have my best interest in mind? So it might lessen trust in physicians. It might lead to pressure to prematurely choose death. It might undermine progress in hospice and palliative care, and it could undermine fundamental physician values. And again, these are, I think, real risks that we'd have to be very open about and study and try to minimize if we can. So what are the main arguments in favor of this practice? Number one is patient autonomy. It's my life, it's my death. I should be given as much choice as possible in this process. The second argument is beneficence. The potential of an escape for suffering. What good can possibly come from forcing somebody to suffer against their will at the very end of life? And then finally, non-abandonment, this commitment to work with people all the way through to their death. So those are the main arguments in favor. The arguments opposed, that this is a form potentially of killing, at least in some definition of that word. What about the slippery slope? Perhaps if we allow this for certain kinds of terminally ill patients, might there be pressure for lesser degree of suffering, lesser degree of terminality? And this could be a violation of professional integrity. There is a history in medicine that doctors must not kill. So again, they have to think that through. So the category of safeguards, again, with assisted dying, voluntariness, this is the patient's decision to make in real time for him or herself. We need to make sure there's adequate palliative care, that we understand the patient's suffering and what makes it unacceptable, and that it's not secondary to mental illness. So we might get consultations, and again, one of the big things that come out of an open practice is you can get second opinions around the edges that you're not sure about. So what might some of the second opinions be? In my opinion, it should always be, if possible, a palliative care specialist around symptom management and decision-making capacity. It might include somebody in the patient's main disease to make sure they've gotten all possible, they've thought at least about all possible treatment options. Psychiatry, if there are questions about depression, anxiety, psychosis, or capacity. We might get an ethics or law consult if there are moral issues, uncertainty, conflicts within the family. And then finally, religious and spiritual consults, depending on the patient's faith tradition. So these are all possibilities. I'm not suggesting that every patient would have all of those consults, but this is just what's potentially out there. So the benefits and burdens of safeguards. We don't want to make it too easy to have this practice available because life might end prematurely. People might change their mind if their situation changes, and we want them to really think it through rather than be impulsive, so having some hurdles there makes some sense. On the other hand, if we make it too hard, it can add to suffering. People will feel they're not listened to, and they might not respect or listen to genuine requests. In my opinion, the safeguard should be similar for almost all of the last resort options. Think about what you put people through when you're going to take them off a ventilator or stop a feeding tube with a patient. Should be similar to those, maybe not exactly the same. So some caveats. Things we clearly need to agree to do better. We have to ensure access to palliative care and hospice for all really sick patients. We have to ensure basic palliative care training for all clinicians. I don't know how robust your palliative care training is for all clinicians in Spain, but if it isn't, that's something to think about for your bioethics group to try to stimulate to get that happening. We want to ensure access to specialty palliative care when suffering gets more difficult. And we need to try to be as responsive as possible without violating fundamental personal values. Getting help with difficult cases will be one of the real pluses of an open system in this regard. Things not to do, we should stretch ourselves to be as responsive as possible to patients' needs and requests, but we should not violate our own fundamental values. Because we have to wake up the next day, we have to go to work the next day, we have to be able to live with ourselves. So our personal values we should not violate. And we shouldn't go it alone. If you find yourself going way out on a limb with somebody and you're not really sure if what you're doing is right, invite somebody else on that limb with you or talk to somebody. Find a safe person to talk to because this stuff is too hard to do on your own, and doing things on your own that's in secret really has a corrosive effect on individuals over time. So the bottom line, about physician-assisted death and last resort options, they're only sensible in the context of excellent palliative care and hospice. Currently, last resort options are unevenly and unpredictably available. In my opinion, all options should be subject to similar safeguards. And open processes are ultimately safer, more predictable, and accountable than secret processes. If we prohibit some options, we must be clear about how patients who would have chosen those options should be approached. So just saying no is not sufficient. We have to say, how then should those patients be approached? Clarity about which options are available and under what circumstances would be beneficial. It reassures those who fear a bad death. It increases responsiveness to extremes of suffering, more ability to address unique circumstances, and more accountability when suffering persists. And just want to reemphasize, if you have a difficult case, you're having trouble knowing how to respond, get some help, get people who are knowledgeable to work with you, and don't go it alone. So thank you. I'll look forward to hearing your questions and thoughts.